Hello and welcome to the next session. So we'll start with the next masterclass, the BPH Masterclass. To moderate the session, can I invite our esteemed speaker and moderators here on stage? First, we'll get moderator Dr. Chua. Will you just please come up on stage, and Dr. Lee. And Dr. Inkang would stay downstairs for now until the case discussion happens later. So can I invite the moderators to introduce the speakers as well? Thank you.
Yep. Good morning, everyone. Thanks, Pradeep, for the kind introduction. The big advantage of me sitting on the stage, I don't need to wear a mask, so that's why I'm quite happy to be here for the next hour or so. So let's get the session going. The first speaker is Dr. Peng Ting Xiang. Doesn't need much introduction. He was from used to work in Tan Tock Seng. Now he's a private urologist in FEM surgery. He did his MIS fellowship at Indiana University School of Medicine and subspecialized in robotic and laparoscopic surgery. He has a lot of interest in minimally invasive surgery for BPH, and one of the stuff that he does best is microwave thermodilation for BPH, ProLift in short. And without further ado, let me introduce Dr. Peng to the stage. Dr. Peng, please.
Thank you, Eugene. Good morning, ladies and gentlemen. First, thank you to the committee for the invitation to present this modality of minimally invasive surgical therapy for prostate. So as you have heard, my specialty is actually minimally invasive and robotic surgery. So I guess I'm invited here because I'm one of the few urologists in Singapore who do this ProLift thermodilatation. So as you know, there are several forms of minimally invasive treatment, MIST for short, and I do perform other forms of MIST like Resume, ProLift, and of course we do the usual TURP and green light. So how do we choose? So hopefully at the end of this masterclass, you'll have a better idea. So TUMT is actually not new, and the more senior urologists in the audience would remember this thing called prostatron, and a few basic biology. So anything above 45 degrees Celsius is required to destroy prostate tissue. However, at the same temperature, around 45 degrees Celsius, as you can see, body temperature is 36.9. So if you go above 45 degrees Celsius, that's when men will start to feel uncomfortable with something in their prostate being heated up at that very sensitive area. So it's a trade-off. You want to destroy tissue above 45, or do you want to give patient comfort? Not to mention the urethra and mucosa injury that affects catheterization rate. That's why in the old days, if you use a low energy prostatron series, so they tend to have higher retreatment rates because they tend to destroy prostate tissue less. On the other hand, if you use a high energy TUMT like the Taji series back then, it can be heated up to 70 to 80 degrees Celsius. Definitely it will kill enough prostate tissue, however, at the expense of higher irritative symptoms and catheterization days. So bear that in mind. So that's what we'll be discussing mainly. So nowadays in the contemporary era, MIST has been accepted as an intermediary role for BPH before the patient progresses to TURP or other major surgical therapy for TURP. Mainly for younger men who wants to avoid the side effects of surgery, such as retrograde ejaculation, or the side effects of BPH medicine. So overview of ProLift, it is a thermodilatation, so-called because there are two techniques involved: dilation of the prostatic urethra and at the same time a focused microwave heating of the prostate tissue to achieve a tissue death. So it's a 45-minute procedure. This is one of my patients in Farrer Park Hospital when he first started. Patient is under local anesthetic. He was about 50 years old, I think. So we just play some nice soothing music in the background. He's lying there with the catheter is tucked underneath his blanket. Try to fall asleep. Totally LA, no sedation at all. So at the end of the procedure, the patient goes home. No foreign body inside the prostate. No catheter. So it was first launched as a pilot project in Farrer Park Hospital back in July 19. Great credit must be given to Dr. Jimmy Beng, the stalwarts of BPH management over the years. So he obtained the GN27 approval for the procedure to be done only in Farrer Park Hospital. So after a very successful pilot study of over 50 patients involving a small group of private urologists, we moved on to a national or rather HSA approval by the company, and therefore we could expand to other private centers, including some to be done in SGH, I believe. So overall, up to last year when I had some data, about 40 urologists were doing ProLift at that time. So outcomes were consistent and reproducible. I'll share some of the data later, and it's been therefore accepted as one of the options of MIST for BPH. Okay, so this is a diagram from Auriga. As you can see, the balloon is here. So this is the retention balloon up there, no difference from the Foley catheter retention balloon. But the trick is in this balloon here. So there's number one, a microwave antenna at the tip, at the proximal tip of the catheter, 1.2 cm, compared to what I showed just now in the first few slides, the older series of TUMT, the microwave antenna were bigger, 3.7 cm or something like that. So this doesn't give a very, very high energy, microwave energy. Number two, a 3.7 cm long balloon dilation balloon that can be dilated to 46 French width. Okay, the catheter itself is only 18 French, not much different from a standard Foley catheter. The second component is actually just a thermometer attached, inserted in the rectum during the procedure. There are 3 dots that measures 3 spots of temperature at various points of the prostate. So firstly, let's go to the microwave antenna. This is a close-up view with L liquid crystals heat map showing the heating pattern. As you can see, it's more heated at the proximal part where the antenna is and less heated at the distal part where the apex is. So it follows generally the shape of the prostate. So therefore, giving a very conformational heating pattern to the standard prostate gland. Another study from the manufacturer, which showed the heat map by distance from the urethra versus the temperature. So you can see immediately adjacent to the urethra, the temperature is actually not very high. It's actually very comfortable. If you can make it out, maybe it's about 40 degrees Celsius, and so therefore it allows the patient to tolerate the procedure awake, and also it reduces the risk of mucosal necrosis and swelling post-op and avoid catheter. So that's how it avoids urethra trauma, put it that way. The highest peak temperature is some distance away from the urethra where the adenoma is, obviously. And it can reach a peak temperature of up to 51 degrees Celsius. So just slightly above what the patient can tolerate, but sufficient to cause tissue death for treatment efficacy. So again, more heat is delivered towards the proximal part of the prostate, towards the base, as opposed to the apex. So corresponding to the shape of the usual prostate. Second part is the dilatation balloon. So as mentioned, it's dilated to 46 French. And also it includes a circulating cooling. Water is circulated within the prostate, within the balloon. So during the treatment, this circulating water is the one that cools the urethra adjacent to the balloon, therefore giving patient comfort, be able to tolerate and reduces mucosal damage. And at the end of the procedure, after the heat treatment is turned off, we actually keep the balloon dilated, fixed at another 5 minutes, so as to produce what we call a biologic stent, so that the protein and the mucosa is dilated and keep it fixed in the dilated state. So we have some real-life ultrasound and scope pictures to show you later. Okay, another MRI heat map. You can see immediately around the urethra where the inner red line is, it shows viable urethral mucosa tissue. Immediately outside, the black areas is a non-viable prostate death tissue. So immediately around the lumen, the mucosa is actually alive, and therefore that's why the patient can tolerate this procedure quite well under LA. Okay, so this is a study showing MCUG pre-op and post-op, showing up the biologic stent after the treatment when the catheter is removed. So you can see the prosthetic channel is kept open despite there being no stent and no catheter. Okay, this is my patient where the pre-op features are on your left. You can see the ultrasound, straightforward, enlarged prostate with a cystoscopic view with enlarged lateral lobes. So on the right, after about a few weeks after treatment, he came back to the clinic, and I managed to get a cystoscopic view for him. You can see the channel has opened up, and even on the ultrasound in the clinic, you can see a channel right in the middle. Quite similar for those of us who have also done other treatments like Resume or maybe UroLift. We do see some of these gaps or spaces in the prosthetic urethra a few weeks immediately after the treatment. So probably gives the same effect. Okay, the third component is a rectal monitor. Nothing much to say, straightforward, 3 probes at the tip. But this is fed back to the machine. And it cuts off power when the energy is above a certain wattage, and therefore it's like an automatic system. You don't have to do anything. The machine just will cut off, and if the temperature cools down, you will turn it on again. So it's a continuous feedback. So it's also like for safety purpose. Okay, so that's where the rectal probe is placed. 3 temperature probes gives you 3 lines during the treatment process. And you can see, for example, at the beginning, it will heat up, the machine will heat up here, temperature will rise quite rapidly. And the moment it says the machine, we set it at 41, and the temperature touches 41, it will signal to the machine to cut off. So you can see the machine actually suddenly switch off. So the prostate will cool down again. And once it falls below, it will start turning on again, and then it will keep it stable to keep this temperature stable at this. So it's a very nice treatment graph. So all we need to do is to make sure the water runs, the cooling runs, the machine is on and all that. So Targis is an old form of treatment. So this table summarizes what's the difference. Lower wattage for ProLift, catheter is smaller. There's a dilatation balloon not present in the older form of TUMT. And post-op catheterization rate is very, very low, taken as we don't need post-op catheterization for them. Okay, I hope I have time to show the videos. This is what the setup is like. The vendor usually takes care of this. I usually don't know what's happening here, but they will flush the tube and all that. Yeah, something like that. So I think she will show you to. But it's very important to check every catheter. So I think she's flushing in the irrigation fluid, okay, to show that the irrigation is running. The vendor can take over this part of the talk if you want, but I think that's what she's doing. Yeah, so that is the irrigation inflow that goes into the dilatation balloon. I think this is quite useful, so we understand the technology behind it. So you can see it filling, so we make sure it runs, the balloon doesn't leak, then it's quite taut, then you turn it off, and yeah. Okay, next video. So this is an insertion. This is where the urologists usually do, and truthfully, this is all we do. That's all we do. Okay. It can be done under LA. You want to make the patient more comfortable, you do it under sedation. Definitely, you don't need operating room facilities. That greatly cuts down costs. Whether in public or private, I'm sure cost is an issue for every institution. That's the retention balloon, no different from your Foley balloon. Inject it. Okay, I'll skip that. That's all. Okay, then the next one is to turn the patient to the side to insert the rectal probe. Okay, so not just that. So we are measuring the length of the prostate. So our DRE, we find where the upper limit of the prostate is. Then we match it to the rectal probe, and there's like a marker there. This thing, there's this plastic thing. So that is at your anal verge. So you match it to where you think the tip of the prostate is, so that we put it in the upper probe. The upper temperature probe would be sitting at the base, the bottom would be apex, common sense. Okay, that's it. So, yeah, that's all the urologist does. So then we hook up the microwave antenna, the metal thing there. Okay, and start treatment. Okay, then you choose your favorite music on Spotify and you start. Okay, so this is what the patient selection officially, and this is also what I practice. So that's what I do, 20 to 80 gram prostate. Because of the balloon length, then I will go up to 5.5 cm. So indications, not much different from other MIST, those who don't want medication or want to avoid side effects of TURP. I would like to take some more time to share the this is the official study. As you can see, all outcomes are improved. But I think what would be interesting to you would be our local study. As of last year, sorry I didn't have time to update the data, but as of last year, we had 92 patients from 9 surgeons all over Singapore. So this is a multi-institutional, multi-surgeon, you can call it, community-based or general. This is not a single center, single study, single expert who has done 100 pro-leaf. This is everyone contributing their own little pool. So this is really reproducible in urologists who have done this, for the first 10, first 20 cases, and you can get these outcomes. So it's valuable to know that this data is reproducible no matter where you are on the learning curve, if even there is a learning curve to speak of. So anyway, the outcomes are improved Qmax, improved IPSS, post-op catheterization rate 4.3% if you take everyone, but that one who was catheterized was already in retention pre-op. So if you take away that would be 3.6%. Retreatment rate is very low. Retrograde ejaculation is not mentioned. No retrograde ejaculation rate. Okay, so in summary, I think no post-op catheter for pro-leaf, well tolerated under LA, preserved sexual ejaculation, rapid relief, and no foreign body to speak of, so you're not worried about any long-term concerns. So take-home message, we have to understand technology just how we understood EX shockwave for stones. We also do IRS, so we have many toys in urology, so it's upon us to choose the best treatment for our patients. Thank you.
In the view of time, I think we'll leave all the questions to the end of the session. We'll look forward to your long-term data for ProLive.
Hi, I'm Kwok. I'll introduce the next speaker who is actually present, Dr. Roon Wang, Society of Men's Health. Hopefully you've enjoyed the dinner with them. Hopefully SUA will have a nice dinner for you as well. Dr. Wang is a leading expert in male urology, men's health, and erectile dysfunction. He's currently serving as president of the Sexual Medicine Society of North America. Dr. Wang holds honorary concurrent and visiting professorships at national and international universities and joint appointment as a professor and chair in urology and director of sexual medicine at the University of Texas and MD Anderson Cancer Center. And he's going to talk to us about the latest innovations in the UroLift technique. Thank you.
Thank you. May I have my slides, please? Okay, I would like to take this opportunity to first thank the scientific chairman, Dr. Lau, and Dr. Chen, to invite me to be here. And also like to thank the Singapore Urology Association President, Dr. Tan, and also Ronnie Tan, who was my long-term friends. And they asked me to come over here, and I'm very happy to be here because this is first time after 3 years pandemic, first time I had an international travel. So don't worry, I have 15 minutes, but I might be able to finish in 10 minutes. And the reason I might be able to finish in 10 minutes is that I did not know that Singapore, the UroLift is really a beginner here. And the scientific committee gave me a talk about the latest innovation in the new UroLift technology. I may get you excited, but probably it's going to take about 3-4 years for you to get those new technology. But stick with what you have. You're going to love it. We just did a couple of cases yesterday, and Dr. Lau and Dr. Colin, Professor Colin and Professor Lau, they did a wonderful job. They're like experts already. So the UroLift procedure, we know that it was approved in 2013. It is really a true minimally invasive procedure, and it is the leading technology in the current so-called functional preservation technology for BPH. And I'm going to go over more detail about minimally invasive surgery tomorrow in the BPH plenary. So today we're going to just focus on what is going on the new technology. So there are two things going on. One is the advanced tissues control system. Another one is second generation of the UL2 system. So this is, again, is for your information, and you probably will not get this for a while. So the advanced tissues control device, this is a very smart design for UroLift technology, because they have this tissues control wing that will easily for you to move the medium lobe and easily for you to remove the large lateral lobe. So this wing is consist of like a two tissues control wing. You see there's a marker. This marker is for the UroLift needle with the needle coming out. And also this edge of this wing are very smooth. Therefore, it will not affect the tissues, will not damage the tissues when you use it. And also, if you look at the slides here, this entire wing is like the width is about 0.4 centimeter. The length is about 1.75 centimeter. This is this is basically suitable for the original UroLift scope. So you do not have to change the UroLift scope system. So you can use the original scope system. And the needle coming out marker will tell you exactly where the needle is going to come out. And so this is very smart design for the people who is skillful to treat the advanced or difficult anatomy of the BPH. And this is basically show how the this device works. This first slide basically show the medium lobe, and you can see that they can use this like almost like a basket, and you control the basket, you move into the prostatic urethra, and then you can basically, when you do this, where with this wing, you can basically improve your view. If you don't have this system, you still can treat the medium lobe, you still can treat a large lateral lobe, but the view sometimes is going to be a little bit more difficult before you deliver the needle. So this is a really very smart design. So look at this picture here. This is pretty large lateral lobe. And if you use the standard or first generation of UroLift, and you can treat this lateral lobe quite well. But the problem sometimes, because this lateral lobe is so big, so when you do compression, and this superior and this inferior area can block your view. But with this advanced tissue control system, you can easily bring this entire lateral lobe on the side before you deliver the needle, before you deliver the implants. And this is the comparison of the first generation and use the UROFAIR ATC system. You can see with the ATC system, the view is much clearer and much better. And we are lucky in the United States, and we started to use this already, and we are quite impressed with this system. Second thing is the second generation of the UROFAIR is called a UL2 system, and this is the first generation. This is one you currently use. This is one 2 days ago. Professor Carney and Professor Lau used yesterday, not 2 days ago. I still get a jet lag. So this has a four clicks you need to control. You have the safety button. You have this trigger. You have this needle retraction button. You have the urethral and cotton device there. That's the first generation. However, with the second generation, just a four click, and one gun, you can deliver 8. You will deliver 8 cartridge. And for the first generation, you will have to switch each time when you deliver an implant. And another thing, very smart design is that you use the traditional implant. You do not use the different implant. It's still the traditional implant. And also they have the smart scope seal. The smart scope seal not only allow you to do this cystoscopy without the put the cartridge, but also without use the cartridge, but also this scope seal can be used as the troubleshooting tool. So it's pretty smart design. And another difference is between the first generation and second generation is this angle. So the needle coming out from the device to the tissues, this angle is a little bit different. The second generation has more angle, so that will make your procedure much easier, and your compression. Like yesterday when we were doing the surgery, we keep telling Professor Carney and Professor Law that you need to compress about 20 degrees. But for this second generation, you do not compress 20 degrees. It's 2 compression maneuver. You compress about 10 degrees, deliver the needle, and you compress further. So why is this? This will give you, avoid the chance to shoot the implant into the bladder. So you have less chance to shoot the implant into the bladder. So this tells you why this angle is important and why you have to use a 20 degree and what happens with the 40 degree angle when you deliver the device. And also this trigger will give you which step are you on. I think most people are very smart, and 4 triggers you will know what you did already. But sometimes you get interfered in OR, people talking to you, you forgot what you did, how many clicks you did already. But this device have those markers that can tell you what you have done already. So I don't have to go to any detail. And another thing about this scope seal, also the troubleshooting tool. Basically, you can use this. You can use this part to cut. You can use this to cut the implant. If for any reason the implant was not correctly delivered, you can use this to cut as well to bring the blue button back here. And you say this is the trigger. You say this is a blue, and this is nothing here. This tells you whether the entire needle was deployed or not. And if you do not say this, and there might not be the needle might not be deployed. But if you say this blue, you know that your needle has deployed already. So a lot of beautiful design. Again, this if for any reason you need to abort the procedure, you can use this device. And you see this aborting hole here. You can just use this device, put it inside. You can cut the needle, so you don't have to continue the procedure. And another beauty is that the Teleflex really stay on the cutting edge. Technology also is they did a lot of work to make the device environmental friendly. So you look at the old package, it's pretty bulky, package delivered, to the operating room. But with this new second generation, they dropped the entire package to about 60%. And so in summary, that this second generation URLIFT is a two-component delivery system, consists of a delivery handle and implant cartridge. And it's used some activate the needle safety button, and it's a single ergonomic trigger. And the deployment sequencing is like a 4 trigger pulls. And the needle position indicator will give you the information about what the needle has been, what you have done with the needle. And you can use do the cystoscopy and remain the device in place. You can use this, You can use this scope seal to do the scope. And scope seal can also will be used for the troubleshooting. So it's a really wonderful technology, and a lot of exciting things is coming up. And I only used about 10 minutes, so I would be happy to answer any question later. But in terms of data for URLIFT, we're going to review this data tomorrow in the BPH plenary, and we can go from there. But what I talk about here is all informational, and be patient, and it's going to come someday, but right now probably it's not going to be available for a while. Thank you very much for your attention.
Thank you, Dr. Run Wang, for showing us all the new toys that the urologists can expect in future for NYST. I'll leave Dr. Chua to introduce the next speaker, Dr. Dean Altman.
Okay, the next speaker, Dr. Dean Altman, will be joining us later during the Q&A session. He will present his talk via video link, and his talk will be on pushing the boundaries of the resume technique. Dr. Dean Altman was completed his training in University of Toronto, and then he did his fellowship in voiding dysfunction, urology, female urology, and pelvic reconstruction in the Memorial Sloan Kettering Cancer Center. So I think we can start playing his video.
Hello, I'm Dr. Dean Elterman from the University of Toronto in Canada, and it's my pleasure to present Pushing the Boundaries of the Resume Technique. I'd like to thank the Singapore Urological Association for the invitation to join you at this UROFAIR. These are my disclosures. So let's begin with the problem. There's a huge number of men diagnosed with BPH every year, but only about a third of them will actually go under active management. 2/3 will be self-managed or unmanaged. And of those men who actually make it to a doctor's office, a proportion of them will go into medications, but a group of them will actually fail medications and need surgery. But in fact, there's a huge discrepancy around the world between the number of men who have BPH, the number of men who make it to the doctor, who go on to therapy, but who ultimately need surgery. So for example, in the United States, almost 2 million men will make it to medications and fail, but only about 300,000 surgeries are done. So what happens to this other 1.5 million men? And of course, there's a group of men who are going to progress on medical therapy or watchful waiting. So the big question is, is there a need for more minimally invasive treatments to pick up the slack and treat all these men who are falling off the back end? Well, what do we want? What do patients want when we talk about minimally invasive therapies or MISTs? Well, they're looking really for a better experience. They want a safe treatment, which is non-surgical, performed under a local anesthesia. They want minimal morbidity. They want it to be a good experience. They want well-tolerated procedure with minimal to no catheterization time, fast recovery and return to work, and high satisfaction. Thirdly, they want effective outcomes. They want rapid symptom relief, improvement in quality of life, as well as flow rate, and durable results. And lastly, they want no loss of sexual function. They would ideally like to preserve both erectile and ejaculatory function. Well, we look at the guidelines around the world, and there are a number of treatments now available. Here in the American guidelines, you can see for average and small prostates, so many different choices. And of course, Resume, or convective water vapor thermal therapy, is included in the guidelines for those who have small to average prostates, which we typically would characterize as 30 to 80 grams. Here are the Canadian guidelines that we recently updated in 2022. And of course, Resume is included in prostates for between 30 to 80 grams, much like other parts of the world. But who do we select for a minimally invasive treatment? Well, it's men who have elected to either discontinue or who have chosen not to take BPH medications. Not every man wants to take a pill. Of course, there may be men who are not receptive to other minimally invasive or surgical BPH procedures. And of course, there are men who have indicated they aren't really bothered enough by the symptoms to have a surgery, but of course, they may be open to a minimally invasive treatment. So how do we select patients? I think it's really important to talk about, number one, patient expectations. What do they want? Why are they selecting a MIST? It's very important to not overpromise, especially when comparing to other endoscopic surgeries like TURP or enucleation. Also, you want to assess values. Why do they want to come in, and what is important to them? Do they want to get off medications? Do they want to avoid surgery? Do they really care about sexual or ejaculatory function? The last thing I would say is there isn't a particular type or phenotype of patient necessarily. I would like to offer minimally invasive treatments or MISTs for all eligible patients coming into my practice. So let's talk a bit about Resume convective water vapor thermal therapy. This is an office-based technique. Of course, it can be done in an operating room. It can be done under local anesthesia or light sedation. A specialized handpiece or scope is placed transurethral. And using endoscopic vision, we're able to deploy a small needle. It's about 1 centimeter. There are 3 rows of holes. And from there is steam or vapor emitted. And over 9 seconds, that heat is transmitted via convection through all of the tissue. The heat causes the cells to instantaneously die, creating essentially a zone of ablation. And so you move progressively the Resume needle 1 centimeter at a time, making these 9-second injections of steam, creating these overlapping zones of ablation. The convective water vapor stays within the zonal boundaries. In other words, the steam will not escape or transmit through the pseudocapsule that separates the peripheral zone from the transition zone or the central zone. So in fact, it's a very safe technique. And we know that ultimately the patients will do quite well once the edema has come down. Based on MRI studies and some further studies that we've conducted recently, we see that the prostate volume typically reduces by about 30%, and the transition zone will reduce by around 40%, and this will take anywhere from 3 to 6 months. We are all familiar with the pivotal study, the Resume 2 study, conducted by McVeary et al., which was a prospective randomized study against sham, which has now been followed out for 5 years. And you can see in the 5-year publication from the Journal of Urology, about an 11-point improvement in IPSS sustained out through 5 years, a significant and sustained improvement in maximum flow rates, as well as improvements in quality of life parameters, again, sustained out through 5 years. And so men want a durable outcome that's going to last and also that has minimal retreatment rates. And you can see the vast majority of retreatments are going to happen surgically within the first 3 years. In this study, 4 out of 6 patients who had a surgical reintervention, which was only 4.4%, were those who had a median lobe that was left untreated. So let's move to the newer evidence around pushing Resume to the limits, really trying to see what Resume can do. This is a large multi-center prospective study performed in Canada. We were able to examine many more patients, almost 230 patients. This cohort of men in our study had much larger prostates. In that Resume study by McVeary, the average prostate size was around 45. Here, 83 patients had prostates bigger than 80 mils, and in fact, the mean prostate volume was close to 72 mils with a range of 20 to 160. More than half of patients had a median lobe, and 39 patients had prior episodes of retention. So on average, we saw 11 injections of steam. The duration of the procedure was very short, less than 5 minutes, and the catheterization time was around 10 days. And remember, this included much larger prostates, including those who had retention, where we leave the catheter purposely for 1 month. And what do we see? Very similarly to the Resume 2 study, very significant reductions and improvements in IPSS from around 22 down to a score actually below 10, as well as a significant improvement in quality of life. The flow rates improved by 60%, and we saw no changes in erectile or ejaculatory function scores. Additionally, there were no grade 3 adverse events or greater noted. So what about large glands? This is, again, the next area of endeavor and research for Resume. Here is our study looking at prostates greater than 80 milliliters, recently published this past April in the British Journal. We had 83 men with a prostate size on average of 105 milliliters, ranging between 80 to 160. 65% had a median lobe and 21 had prior retention. On average, we used around 13 to 14 injections of steam. This was with a single handpiece. The procedures, even for these large glands, remained short at 6 minutes. And catheterization time was again around 12 days. For most of these large prostates, we do like to leave the catheter in anywhere from 7 to 14 days. Notably, again, even for a large gland in this large cohort, we saw significant reductions in IPSS from around 21 down to 8, and significant improvements in quality of life. Flow rates improved by 55%, and once again, no significant changes in erectile or ejaculatory function. So again, I think this gives us more information, more data to support the use of Resume in very large prostates. Here's a study that we looked at, a multi-center international study with some names you may recognize as Resume as a salvage treatment for previous BPH surgery. Here we had 19 patients who had previous TURP, UROLIFT, PAE, Resume, TUNA, and we wanted to see whether Resume could be performed in a very focused way to treat recurrences. And in fact, we saw at 3 months a significant improvement in IPSS from 23 down to 9. Quality of life scores improved, as did flow rates, and no patients had to restart medications. And so Resume could certainly be used as a salvage treatment to rescue these patients. What about Resume for catheter-dependent urinary retention? Well, this was a real-world study performed in Canada at our clinic, looking at men who came in with a catheter. So these are 16 patients who, again, had a very large average prostate size of around 84 mils, ranging between 41 and 158 milliliters. The vast majority, 75%, had a median lobe. All of these men had one previous trial without catheter. They were placed on medications, 87.5% of them, and all had the opportunity to acclimatize to an alpha blocker, fail, and then ultimately go on to Resume therapy. So what do we see? We gave slightly more injections for these retention patients, 14. The catheter time was a little bit longer, close to 30 days, which is the standard within the urologic community. But what do we see? We actually saw catheter-free rates at 1 month, 13 out of 14, at 3 months, 14 out of 14, and at 6 months, 15 out of 15. So essentially, all patients who were followed, more than 95%, had successful trial without catheter. So here's another notion of sort of flipping things on its head. This was a pilot study we performed looking at less is more for Resume. In this study, where average prostate sizes were around 52.8 cc's, and the average IPSS was around 20, we purposely gave a single injection of steam per side. So these are 50-gram prostates who, instead of getting 2 or 3 or 4 injections per side, only received 1 injection per side. And what this demonstrated is that IPSS was reduced at 3 months by 4 points, but by 6 months it came down by 8 points, and by 12 months, like we saw in the other studies, an 11-point improvement. Quality of life improved, as did maximum flow rate. The catheter time was actually quite short, around 3.5 days, and we think that could even go lower. So perhaps more steam is not the answer, less steam is the answer for the average prostate. And so to conclude, I think minimally invasive therapies fit somewhere very nicely between medication and surgery. It gives men an alternative to medications. Remember, those on medical therapy is the largest pool of patients from which we can draw. It is very important to consider men's individual values. What's important to them? Recovery, the anesthetic, sexual function, catheter duration. I do think minimally invasive treatments, and particularly Resume, can be a rewarding option. It will broaden your choices, but you must choose wisely. Look to the data, look to the evidence, see how we and others have really started to expand the applications for Resume, and you can give it a try in your practice. So with that, I'd like to thank very much the organizers for this opportunity to speak at the UROFAIR, and my best greetings from Toronto, Canada. Thank you.
So I'll introduce the next speaker, which is a recorded presentation. It's from Dr. Fernando Gomez Sancha. He's the head of the Department of Urology and Robotic Surgery at ICUA in Madrid, Spain, where he specializes in laser prostatectomy with green light and holmium lasers and radical prostatectomy. He also works at the Hill Clinic, where he performs laser prostatectomy. He's an early adopter of the green light laser and has trained surgeons to use it in hundreds of hospitals around the world. So I'll move on to the recorded speaking.
Hello, this is Fernando Gomez Sancha, and I'm going to discuss the challenges and solutions in the enucleation of the prostate. The first question you might ask yourself is why adopt enucleation of the prostate? And people tell me, TURP is still the gold standard, and I tell them, TURP is the most used treatment in the world. And that's why they call it gold standard. So if you think about cars, a Toyota Corolla is the most used car in the world, but it's not the best. And anatomic endoscopic enucleation provides superior results as compared to TURP, and there's level 1 evidence to support that, especially for holmium, and a little bit less quality of evidence for thulium for enucleation, but you can offer bipolar holmium thulium enucleation of the prostate. They seem to share the same excellent results, and there are many, many reasons why this option of treatment is better than the classic TURP and, of course, open surgery. When I was invited, and I thought, how should I tackle this presentation? And I asked in the internet, in Twitter, and I got a lot of people making suggestions. So I will try to cover some of these suggestions. And I'm going to discuss a number of points, going from how do you plan for the purchasing of the equipment, how do you convince your manager, to other more technical issues of urological interest. You know that there is already published information looking at the cost of buying a laser and starting to do a program of HOLEP. And also there's a lot of, there's more and more evidence coming out showing that it can be performed in less than 1 day surgery or ambulatory surgery. So that might make it attractive. Of course, you don't want to ask your manager for money. You have to sell him the idea of how your department would look if you change, if you stop doing open surgery, if you stop doing TURP, if your patients go home the next morning or very fast, some of them even in the same day, and you don't have to cross much blood just in case they bleed a lot, and you can treat old and weak patients without ITU risk. And of course, if you calculate the number of free beds that you're going to have for other procedures, well, you will be more convincing, of course. You have to budget not only for the instruments that you will buy, but also for the teaching and learning costs for you and for your team. In private centers, many urologists tell me, I do 30 prostatectomies a year. How can I afford to buy a laser? But I tell them, if you do 30 now, when you do HOLEP, you will do, the first year you will do 50, the second year you will do 100, and then 200, and it will only grow. So what looks like a very big investment becomes less and less big when you master the technique and you can offer the excellent outcomes for patients. Of course, you have to aim to purchase very good equipment because this is a surgery of maximums. You cannot do it with a bad laser, with a bad camera system, with a slow morcellator, because then it's a pain. You need to try to get good equipment. Of course, many people start their experience on their own, in their own hospital, and then, of course, the anesthetist sees this very long operation and he's discouraged. The manager, everybody's looking. So my suggestion is you invite someone who can do a good job, who can amaze everybody. We can do 5 HOLEPs in one morning and send the patients home very fast. And when you go to the room, they're not bleeding. And this will help you convince everybody that this works. And then, of course, if they see you starting and you're slower and it takes longer, they will understand much better that you have to learn. They will not say this technique doesn't work. Why don't you do 2 TURPs in the time you do one of these operations and things like that. So the most important factor for learning is commitment. If you want to learn, you will learn. This operation is not difficult to do. It's difficult to understand. The anatomy is different from what we are used to. And luckily, there's a lot of video online that you can watch with many centers publishing their own videos. I myself have almost 40 full-length videos that you can watch. And I tell you, if you spend the time watching and listening and trying to understand the concepts, the moment you sit down to do one of these procedures, you will be much better equipped. Of course, it's always good to have a visit to a center of excellence. And I think the best way to do this is to have a mentor coming and have an arrangement so he can come many times, not just one, but for example, monthly. I have done this with several centers where I went. I did the bigger cases, the difficult cases, but every month I had a chance to see how they did their smaller cases, easier cases, and they had a chance to see me doing the difficult ones. So the learning process was not only just one day, but several days over several months. And then usually these teams tell me, don't come because I perfectly can handle any prostate that comes to me. It's important to know that this is a teamwork. You need to train your team, and it's better if you can have a stable team. And of course, choose the smaller prostates to start. Many people ask me, how do you avoid stress incontinence? Because we have seen in my publications that a big number of patients can have temporary stress incontinence. They get better and they forget about it over time. Some of them are incontinent, but they're very happy because, before they had a catheter or they had a very, very slow flow and difficulty to void, and they pee so well now that even when they leak a little, they're not so negative. But of course, you want to avoid this. And of course, patients have incontinence because there's some damage to the sphincter, although it's not total damage to the sphincter, because as you know, and Tony Mundy used to say, only God can make a sphincter. So the reason probably, and this is what I believe, and it seems to be supported by my clinical experience, is that the mucosa of the sphincter has an important role in continence. It has a lot of sphincter fibers. This is the lysosphincter, and we know the anatomy much better. And the truth is that with the classic technique, the dissection of the apex was quite careless about the sphincter. You would see this curtain after trying to do the lateral dissection on both sides. And this represents the mucosa of the sphincter that has been ripped off the sphincter. And that's probably why patients are incontinent for some time, and then they recover continence when the mucosa grows back. So the en-bloc approach with early apical release allows for a progressive and careful mobilization, and this is the key word, mobilization of the apex and early liberation of the sphincter to protect the continence mechanism. So we start the procedure by doing this white line. The white line, we are telling, the prostate, we want you to break the mucosa here, where I know it's safe, and not, peel the mucosa off. So just by doing this white line, irrespective of what technique you use, 2 lobes, 3 lobes, 1 lobe, you will have better continent results just by doing that white line at the beginning. But the difference is that when we finish the case, we have a preserved sphincter mucosa, and that shows with nearly very, very few patients having stress incontinence after the operation. So the operation starts with localizing and developing the posterior plane. You enter in one side, then the other, then you cut the frenulum of the varus, develop the posterior plane, and here is where the mobilization is important, because if you take your dissection a little bit inside, in the direction of the bladder neck, you're going to truly mobilize the apex, and then the access to the most anterior part is going to be much easier. Of course, you have to cut the distal attachments first before trying to dissect the corresponding area, because you don't want to put tension on the sphincter. And it's very important that at the beginning we have to cut and deepen this white line, cutting on the adenoma. This is the sphincter, this is the adenoma. And if you do a cut on the adenoma, you will have much better access and you will be able to get to the good plane, remove all the adenoma, but preserve the sphincter very, very carefully. And of course, once you dissect the other side and mobilize the apex, it descends a little bit. And this descent allows you to do the 12 o'clock area without tension. Of course, initially we cut more horizontally, but once we think that the sphincter has been left behind, we can go again and also to look for the good plane also anteriorly. Once we have the apical liberation finished, the irrigation is going to be excellent because we work in a very small space and we just have to go around the adenoma following the line of dissection. And here's what I tell my residents, please sit down and now try, because the operation is going to be very safe from now on. We enter the bladder anteriorly and we cut the bladder neck circumferentially, and finally drop the adenoma into the bladder. And this is the advantage. When you finish the en-bloc enucleation, you have a sphincter that is covered by mucosa exactly, the mucosa was broken where you decided, and not a peeled sphincter like this that will probably cause some temporary stress incontinence. This is a series of 80 patients that we followed up prospectively, and we found only a 1% incontinence rate after 1 and 3 months, which is really amazing. And there's a Chinese group that compared different techniques, and they recommend a technique that closely resembles the technique we described. Their drawings also resemble our drawings, but their results also resemble our results, which means that we are on the right track. And the following reflection is very important. Many people tell me, what settings do you use? As if the settings, it's like, I like drawing. And when I see these guys drawing, I think, what pen are they using? But it's not the pen. And the settings is only one of the factors that determine tissue laser interaction and the effect on the tissue. So I'm going to discuss the other 3. The first one is the working distance. You need to have to get acquainted with the laser you're using and master the working distance, because if you're too far, nothing will happen. If you're too close, it will be very disruptive. So you have to find the different tissue effects that you can get with your laser and master these effects to adapt to different clinical situations. Sometimes you want to cut very fibrous tissue. Sometimes you want to carefully dissect a very thin plane. And so this is a very important factor, and the working distance is going to condition this effect. Of course, there's another important factor, which is the speed of movement. How fast you're moving your fiber around is also going to determine how this working distance is going to work when you move. And for example, if you move too fast, maybe there's no time enough to do good hemostasis. You see, following these lines is very nice, and this is why the en-bloc technique is easier to perform and to understand and to learn, because you see the lines are quite smooth, and then you have to follow these lines. And if you have a uniform line that you are developing and looking after during the procedure, you will be able to keep a good distance that produces a nice effect during the dissection. But of course, the planes are changing direction all the time when you do HOLEP, and then the way to adapt to these curves is going to be to aim your laser more medial or more lateral or against the line of dissection. In general, my recommendation is in the first half of the operation to fire against the line, because the planes are opening, they're going up, they're going down, they're going lateral. But then, of course, when the planes are starting to close, where you approach the bladder neck and you're going down to the bladder neck and you're going up to the bladder neck from below, you have to aim closer to the adenoma, just like the motorbike driver, gets closer to the center of the curve when he has to take a curve. So you see in the upper part, when you fire against the side of the adenoma, you will get some action cutting the fibers that join the adenoma to the capsule, so you can progress in your dissection. Of course, you will have to go up, 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 up as you go. But if you fire against the line of dissection and the plane has already changed direction, you might risk perforation. Often we find adenomatous nodules that grow into the capsule and push it and thin the capsule. My preference is to take them out. Some surgeons tell you cut them and leave them in situ. It's very hard that these nodules will grow and obstruct, but I have seen it. And I think if you can take them out, and you can, if you master these 4 elements of the laser interaction with tissue, you can fire against the edge of the nodule and dissect them from the thin capsular without perforations and without extravasation. And you go home very happy thinking that you really cleaned the fossa from BPH tissue. With the big middle lobes, there's an advantage to en bloc, and that is that when you have a prostate that doesn't even allow you to enter the bladder because the middle lobe is too big and too long, with the en bloc approach, you can enter without any trouble. That's why I hear a lot of American surgeons saying, I have to do a perineal urethrostomy when I do a big gland, but it's not my experience. I have never done a perineal urethrostomy for HOLEP, and I do 60 to 100 cases a month. So I think maybe the exception might be the patients with semi-rigid prosthesis, penile prosthesis. Sometimes if the prostate's big, you might not reach, and you have to push, and you have to generate a lot of traction in the penis and the prosthesis. But again, in the cases that I had done, I managed to operate the patient without having to do a perineal urethrostomy, which is a strategy in the difficult situations. Also, a lot of people ask me, how can you push such a big adenoma into the bladder? And the trick is to do it by rotating the adenoma. So you initially lift and push one of the lobes into the bladder, and then you continue the rotational movement by pushing the other lobe in the same direction, so that the adenoma will go sideways into the bladder. And in case you cannot negotiate the passage of the adenoma into the bladder, you can split it in 2, or you can try to do intracapsular morcellation. The key to avoid perforations is to control your laser, to know the effect. And once you do your en bloc early apical release, I think you have to constantly judge where do you aim your laser. So if you start seeing the thinning of the capsule like there in the video, you have to start correcting your aiming, and this way you will do only small perforations that have no clinical relevance. If you see that there's a big hole where there could be extravasation, you can do transrectal ultrasound intraoperatively to check if there is a lot of extravasation. And of course, safety is very important. But most of these perforations happen at the end of the procedure, and often you can lower the irrigation bags and you can try to, let's say, speed up the procedure and finish. Of course, it's your call as a surgeon. If you feel that you are out of control in the operation, you don't know, and you feel that the patient is going to risk a complication, it's probably better to put a catheter and come back another day. Regarding the orifices, also, you have to be careful, visualize them, and of course, depending on the source of energy you use, you can decide to do something about it or not. With the green light laser, the penetration depth is significant, and often if you do a lesion, it's better to stent or resect the UO to avoid leaving this coagulated tissue that will probably scar afterwards and generate obstruction. But with holmium, thulium, and thulium fiber, I think the risk is much lower. And often in my practice, I just monitor the kidney of the patient. And I have to say, it's very, very, very difficult that we obstruct ureteric orifice with a laser. Morcellation is a teamwork. It's very important, because you have to keep your eye on the screen that your team supports you, and you need to train your team so that they help you properly. It's important that the water keeps flowing in and that people is present in the operation when they're helping you and not distracted, because that could cause fatal, or well, not fatal, but terrible errors and unnecessary errors. So for morcellation, you have to have it ready when you need it. Don't start the procedure when the morcellator is not ready. You have to check that it works. Keep the water flowing in and monitor this filling. You can. What I do is to check if the mouth is not visible. I know that there's a lot of tissue going out and not so much water. If I'm sucking a lot of water, I have to stop and let the bladder fill again, and try to morcellate only with good visibility. So, often we go to fish the pieces near the bladder wall because we have better visibility of the surroundings. But then, of course, when you want to start the morcellation, you have to lower your hands and you have to see these black triangles. You see here, we can see the bladder. Then I lower my hands and then the morcellator is away from the bladder wall, and then you can start the morcellation. And I want to make a reflection. Of course, it's always safer to put a catheter and return another day if things get difficult. If you don't have the control of the operation, you will never regret you stopped the procedure. The patient will never tell you, he's not happy with you because you care about his safety. So he will forgive you, and you go back 3-4 days later, everything will be much easier, and you can complete the procedure without any major problem that you will have to regret, for all your life if you don't have this clear judgment. So to finish, I want to say that this is the best time in history to learn to do enucleation. There is new technological advances, excellent lasers that provide excellent coagulation, fast morcellators, thinner scopes that adapt to smaller urethras, and then the surgical technique has advanced to make it a much more safe procedure for the patient. And we avoid early incontinence, which was a little bit frustrating for both surgeon and patient, and is now no longer a problem with this operation. So I hope you enjoyed the talk, and I will be there for the questions and answers.
Yeah, thank you. I think now is the time for Q&A. So anybody have any question, you feel free to type in your questions or. Okay, before that, we have the case discussion. I think Dr. Vinit has a case for us to discuss with all the panelists. So we'll get them to lock in as well. Yep, they're here now. I welcome both gentlemen. Can you see us?
Yeah. Hi, Dr. Dean. Hi, Dr. Gomez. Thank you for joining us.
Hello, good morning.
Excellent
Thank you.
talks. So we have Dr. Nuang and Pang. I'm just going to include everybody into this discussion. So pardon me in case we trouble you a little bit on and off. So I thank all the sponsors for this session. And so we have this 52-year-old man who's a professor. Adds to a little bit more anxiety. Now he's sexually active, doesn't have children, doesn't want children. He's intolerant to alpha blockers, and he has vertigo. That's why he said, I can't take it. Now he took finasteride, and there was no effect. So he came to me and he said, I've spoken to many people, and they said, we should get a surgery done. So bothersome LUTs, worsening over 2 years. But the flow is not too bad. And that's your bedside ultrasound, which shows the prostate isn't too bad. It looks quite innocent, if you can see the scan. So I'll start off with the minimally invasive procedures. So Dean, would you consider resume? I think so. Or is there something better that you feel may be better?
I think resume would be a very reasonable option for someone like this gentleman. He's younger, he's sexually active, not super concerned about his ejaculation well, that's not true. He doesn't want children. He may still want his ejaculation. He's failed medical therapy, and his prostate is a very reasonable size, 62 milliliters. So if you want something which is quick, less invasive, less anesthetic, with the option of preserving sexual function, I think resume would be a very reasonable option.
So Dr. Runwang, is Urolift also an equally good option, I think, for him?
I think this patient, I think the UROLIFT is probably in my practice is going to be the best option, and it will be my first choice. The reason for that, he's such a pretty active young person, and what?
Sorry, carry on. I think there's
Okay.
some.
And obviously, other option can be, other minimally invasive procedure can be a good option for him as well. The reason I would like to do the UROLIFT for him was that, number one, he can get an immediate relief of the symptoms. Number two, we can avoid a catheter, a long-term catheter. We know that Rezum is a great option, but and he will have to wear a catheter maybe for a few days to a week or two, even sometime. So if you do the UROLIFT procedure, you can see the results immediately. And in my practice, 90% we don't put a catheter after the procedure. So this gentleman, in my opinion, and I will offer him a UROLIFT first.
So he's in Singapore, Dr. Pang. If I referred him to you, ProLive is your first choice, I'm assuming, or it's an equally good choice, is that?
Yeah, I think the reasonable answer is an equally good choice. In this case, if I would sway him towards ProLive, if he's a very busy professor, he can come between his classes, give me 45 minutes, I would treat his prostate and go back to his next class.
Wow. So I didn't ask him that, but then that's a good selling point. So Vejin, this gentleman wanted a second opinion, and I referred him to you. In your discussion with him, would you offer him a day surgery in your office, or would you prefer it in the OT and the sedation or anesthesia?
Okay, I mean, it really depends on the setup. If the patient comes to me for a second opinion, I have a side advantage because I offer both procedure other than ProLift. So I do UROLIFT and Rezum. So I'll just go through with the patient the indication, and in this case, I think both procedures are suitable. So how I'll counsel the patient at that stage is that I'll just tell them the advantage of each. For the case of the Rezum, there's no foreign body. So some patients will tell me that they do not want to have a foreign body inside. But for the case of Rezum, they need to understand that they need to be on a urinary catheter, and the catheter will be there. Depending on this, based on this size of 62, I'll just tell the patient that it will be 7 to 10 days of catheter. Next, I'll talk to them about the retreatment rate. The retreatment rate based on 5 years data that we have is 4.4% surgical retreatment rate for Rezum and 13.6% for UROLIFT. So I just give all the data to the patient and depend on what the patient wants.
Does this 4.4 and 13.6 sort of reflect in your practice as well here?
I think it's still too early for us because we only have probably 2 years data. So we'll monitor. But based on the international data, which is what is available, I will just counsel the patient accordingly. Of course, I'm talking about this patient per se, but of course those with median lobe and all will be a different story. Yeah.
Dr. Rung Wang, do you think it will make a difference for an Asian population versus an American population when we start looking at these sizes of prostates and PSAs as criterias? Or it's just, it doesn't matter, the guidelines apply everywhere. But do you think this role?
No, I think it matters. I think the Asian people and the American people, Latin America is a little bit different for sure. And we got more bone strike in terms of, beginning, when you are in the beginning of the treatment with the UROLIFT procedure, you get more bone strike in the Asia population and less in the United States. I think the size, the pelvic anatomy is a little bit different. So you have to be very careful at the beginning. You need to understand, try to use every technology to stay away from the bone. Okay. In terms of the PSA, I don't really see much difference in terms of the effect of the UROLIFT to the PSA in Asia versus American people.
Dr. Gomez, don't feel left out. I just wanted to know, enucleation is also a choice for this professor, or you rather he went to Dr. Dean and other people first? Sorry, I think you're muted. We can't hear you now. Sorry.
Excuse me. I think it depends on the wishes of the patient in terms of durability. So I have a discussion with patients as well. I think there's a move towards considering sexual function very important, but we have seen patient groups that were, for example, unhappy with circumcision, but I haven't heard of a patient group who complaints about the retrograde ejaculation. So I think this is more industry driven, and of course you have to think about the future as well. So I tell the patients, maybe you want to ejaculate, but you have to consider very carefully the trade-offs. And in my experience, when we do enucleation in these patients, you can do this kind of gland as a day case as well. And that means that the patient is going to stay in the hospital less than 1 day. The catheter out is out the next morning. There is very rapid improvement. There might be a little bit of blood in the urine for a couple of days. There might be some irritation for some time. But this option would offer him the best chances of durability to have a single treatment in his life. Of course, he would probably surely not ejaculate. But I think now we have to discuss with the patient. But I think offering the patient a definitive solution for the problem is quite interesting. I don't know how old is this professor, but okay. 52. Okay, he's a young man. So yeah, we have to discuss the options and what he wants, and also reflect that many of these patients that we treat who have 65, 70 years of age will probably have a chance to recur down the line. And so yeah, for me, HOLEP would be a great option as well for this man if he wants durability.
So I didn't trust my bedside ultrasound, and he went to Dr. Lee Cocking, and he had elevated PSA because he does a PSA much better than me. And Cocking, now he found this MRI and came to you with that fancy-looking IVPP over there. So what would you tell him now? That you met the wrong doctors and he should have just come to you straight away? Or Dr. Lee Cocking? He's come to you with this picture.
Yeah,
so your investigation.
I think BPH is reaching a point of whereby I think the term is called shared care with patients. There's so many modalities to treat prostate that nowadays that patient will definitely ask around for second opinions and will want to know what you intend to do with his prostate.
So will you offer enucleation or will you still offer him a mist? Because, keeping his profile.
I think he's young enough to consider all options.
Okay. So Yunggang, he still doesn't believe KY, and he comes to you. And then he tells you, this shape of my gland, I'm professor, I did my studies, give me one treatment. And what would you like to do?
Well, looking at it, this patient has quite significant intravesical protrusion of the prostate. I mean, it looks like at least probably a grade 3. The good thing is it's only the median lobe. Sometimes we do see them go circumferentially with protrusion, not only in the median, but lateral and also anterior lobes. Those are the ones that I'm really hesitant about offering any kind of MIS treatment for him.
So you remember seeing this uroflow, not too bad. It is obstructed, not too bad. Do you think giving the treatment at all is now really necessary, or watchful waiting is a choice, like just watch him? Sorry,
what's his IPSS score?
His IPSS is about 21. That's because he was complaining that he has to go a little more often sometimes. Some days are good, some days are bad.
Yeah, so I think the Euroflow in itself is useful to have some quantification of the flow rates. It doesn't say anything about how the bladder is working. Is there overpressure? Is there a decrease in compliance because of thickening of the bladder? And all that is not represented in the Euroflow. Okay. So I think the IPSS score is useful because it talks about not just the flow issues, which are related to bladder contractility and all that, but it's also about whether there are secondary effects on the bladder in terms of reduced compliance, increased instability and all that. So okay. I think we are treating not only for flow, but we're also treating for symptoms.
So bladder preservation is very important. I think that's a very important take-home message when you counsel a patient. So I gave him all these choices because...
May I make a comment about the...
Sure.
So, in terms of offering him any options, I think we cannot offer him the procedure just with those pictures. So the best thing we need to do is to do a flexible scope, find out what's going on, and then you can evaluate. And at that time, you can have a better consultation to the patient.
True. So I did not do a flexible cystoscopy, but then I did tell him all the choices, and I said, like everybody here has alluded to, I took my time to discuss with him, and he asked me, is there any other miss? So I said, the only person I know who does aquablation is in Canada. So Dr. Dean, aquablation, your cup of tea for him?
Aquablation is certainly an option amongst the many that we've presented. Aquablation allows you to do real-time image guidance. There is no contraindication to doing a median lobe, and we've demonstrated in a meta-analysis that the outcomes are the same whether or not there is a median lobe present. Of course, the technique has to be altered somewhat. You have to dip the tip of the scope. You have to ensure you know where the ureteric orifices are, that they're not pulled up underneath the median lobe. But you could definitely do aquablation. It would be a very straightforward case. Right up there, along with enucleation, middle lobe only, TURP resection is a nice option. And for the mists, I would still say that Resume has the option of doing a middle lobe, as you can put the steam in, whereas I wouldn't put a prostate stent into a large middle lobe.
Resume from you, so I went ahead and said, okay, fine, let's go ahead with the Resume, because I find that to be easy. We just discussed this, the flexible scopes. I think pre-op investigation, nothing. But I did offer him to do it, since it's just shape of gland, to do it under anesthesia. So now what happens is, I had an unfriendly anesthetist, so it was under spinal. And I put my scope in, and you can see the view over there. It was such a big gland, the median lobe only, sticking right out, very vascular, and it just bled, because I think my scope hit it. And it bled so profusely that I had to put in a 3-way catheter and shift him to the recovery. And then I was contemplating in my mind, what do I do next? So it's unsuccessful. Patient continues to bleed. Very anxious patient, and he got even more anxious, Dr. Me. So I said, okay, I'll just do a cystodiathermy for time being. Luckily to spinal, counseled him, he was okay. Spinal was still working, took him back to the OT, and I decided to do a cystodiathermy. Is my decision right or wrong, Dr. Gomez, that I should have done a cystodiathermy, or I shouldn't have done anything, but he kept bleeding? Dr. Gomez? You need to unmute yourself, sir. You're still muted, Prof. Would you mind unmuting your mic? Okay.
Okay, here I am. Sorry again. Yeah, well, there's some consent issues. I think the patient, maybe it's a fast decision, but it's also, let's say, an emergency situation. I think if you're there with a resectoscope, you might as well resect the middle lobe, and try to make things better. I think just coagulating these vessels is not so safe, and I think resecting the middle lobe would be a better option. Yes, I think in this patient, I don't do Resume, I don't do UroLift, so because I have a busy enucleation practice, but occasionally we do partial treatments in patients who are motivated to keep ejaculation, and that is an interesting development in enucleation. We can enucleate the middle lobe in a case like this if the patient wants to preserve ejaculation, and they tend to do very well with this kind of middle lobe. But if I was in your skin, I would have just gone in and resected the middle lobe.
So I went back in, and I just did a cystodiathermy. I was quite happy with the outcome, and I said, shift him back. I resumed the discussion with the patient on what should I do next. And then the bleeding restarts again. He's still in the recovery room, and the 3-way gets blocked, and everybody is tensed. So I asked for help. And my colleague, Dr. Lee, was not around the hospital at that time. So I asked somebody, can you come? Because I'm a bit tensed. So I thought to myself, I should have done the median lobe resection. So I got somebody who's really good with the resection, and then they did the median lobe resection. Now, patient was adamant on not having an enucleation at this point still. So we decided to do the median lobe only, because he also didn't want to do a PAE. So we did the median lobe resection. As you can see, 40 grams of resection done. And I was really thinking, okay, hopefully the force be with you and me. But life is like that. Shifted him to the ward. Nice, clear CVWO. Patient and this doctor, everybody is happy because all things are good. 4 days later, I removed the catheter and sent him home. And 2 days later, he sent me this WhatsApp message. And that's when all alarm bells went off. So I was like, oh goodness, we're in a mess again. So I immediately called Dr. Lee. Okay, what would you do to help me out, please? Would you offer a PAE? Or would you now tell them, go ahead and do a enucleation? Because I think everybody else who does mist over here is just sitting quiet. It's become a miserably invasive surgery treatment, not the minimally invasive.
Well, I know the history of this patient, you have to stop the bleeding and get rid of the problem. I like doing enucleation because it solves the problem. But obviously, in this patient, you have to let him know that you will probably lose your ejaculation, which is why he started off on the journey. But sometimes when they're so miserable, they come round and they understand that that's the last time they will ever need a urologist.
So Dr. Gomez, he finally earned his enucleation rights, I think. Do you think it's a little bit difficult to do enucleation in these patients? Simple yes or no?
No, not difficult.
So we took him up. I kept calm. Then, I said, okay, just go ahead and do. So we treated him with some antibiotics, of course. We actually went in to consult because I was still not convinced it's the prostate which is bleeding, but maybe he has some bleeding issues. He was fine, counseled him once more for PAE, but he was still bleeding. And he had ARU now, and he had an IDC inserted, so it added to the nightmare. And then I just took him in, not me, but I got my colleague to do a very nice enucleation job. And I still believe in miracles. So just looking back at it, Dr. Wong, would you have done UroLift for him now that you see retrospectively what's happened? Would you still have bothered to try the UroLift? Because I'm so scared that my scope caused so much of a trauma. Imagine the clips.
So I think you have to know your limits. If you feel comfortable, you are expert into handle the medium lobe. If you can find the sulcus between the lateral lobe and the medium lobe, you can bring this medium lobe into prostate urethra. You can give it a try, and there's no reason not to give a shot. If you can see this anatomy well with this flexible scope, you can find the space between lateral lobe and a medium lobe, and there's no what should I say? There's no stop you. Nothing can stop you if you feel comfortable.
We should have done the flex scope as you first suggested.
Exactly.
Yung Kang, would you have still done a flex scope in private practice? Do you offer the patients a scope as an investigation?
Yeah, I do on a regular basis nowadays, especially if I'm going to do a MIS procedure. It helps also guide in terms of which procedure I might choose, whether UroLift or resume. Yeah.
For ProLeave too, while we just sum up the whole thing, ProLeave as well.
So on the bedside ultrasound, we should be able to see the IPP. So that would dissuade me from doing ProLeave, to be honest, because understanding the technology of the microwave antenna, we wouldn't be able to heat the median lobes, this kind of median lobe satisfactorily. Yes.
All right. So I think eventually all is well. The patient's peeing quite well, and we're happy. He's happy. So I think the bottom line for everybody here is that patient counseling is so important that anything can go wrong anytime. And the expert panel here has really been kind of you to sort of pitch in and help me decide that actually I didn't do something too wrong. It can happen to the best of us as well. So thank you very much. For the amount of time, maybe we have another case, but no, okay, sure.
Yeah, thanks, Vinay. I think I just want to end off for the sake of all the residents here, that you really encounter difficulty and patients bleeding the ward. I think I will go for TURP. At the end of the day, TURP is a gold standard. It's well tested, I think, and most of us are very comfortable with it. And TURP I think today, I think is still my first choice when it comes to complex, difficult cases. With that, I think I'll end the session. Thank you.
Thank you.